Introduction. All right. So for those of you who might not have met me yet or have worked with me yet, I am Bala. I am the pharmacist that rounds with the post-surgical team. I also do take a look at the chart review, the readmissions, the transplants, and the VADs on the other service, the 7 center service as well. But I mainly round with the post-surgical service. And today we will be discussing immunosuppression as a whole. We're going to talk about what we use, when we use, why we use them, side effects, some studies that kind of talk about why our practice is the way that it is. And we will have some assessment questions sprinkled throughout. So feel free to jump in and answer those. Okay. So the objectives of this lecture will be to review immunosuppression agents used in our transplant recipients, also to identify common adverse reactions, which we do see a lot, drug interactions, and appropriate monitoring parameters for each of our immunosuppressive agents in their different stages that we use them. So as a whole, the role of immunosuppression is it's very large. We can use it in many different ways and in many different steps of our transplantation process. We can start it from prior to transplantation to desensitize our patients. And this is to kind of help reduce our panel reactive antibodies to help prevent any rejection in the immediate phase, and also to help match our patients with potential donors. We can then use it as an induction, which is given at the time of transplant. And this may help delay our calcineurin inhibitor initiations, which could help protect our patients' kidneys, and which we will discuss in the future as well as prevent, again, that rejection. We can then use it in our maintenance phase, which is initiated at the time of transplant. And this is chronic therapy, and this will be used indefinitely for a majority, all of our patients. But, at times we can hold it if our levels are high. We can change the medications if they're not tolerating it. But as a whole, in maintenance, they are kept on it forever. Finally, we can use it as an agent to treat rejection, not only to prevent rejection, but to treat rejection. We can use bolus doses of our, I'll discuss some of our IV and anti-rejection medications, or we can increase the doses of our maintenance immunosuppression to help treat that rejection. So this is a nice picture that kind of, I know it's kind of busy, but it summarizes where a lot of our agents work within our T cells. So if you can see cyclosporin and tacrolimus, which work in the T cells, and they inhibit calcineurin, which you can see kind of listed here. And circle it for you here. Then we can move on to our co-stimulation, which is CD80 and CD86. This is where our belatacept will work, which we will discuss as well. We can go on to our IL-2, which is where basiliximab or Simulect will work. We will discuss that as well. Moving on to the mTOR inhibitor right here, which is our sirolimus and everolimus. We have our mycophenolate, our mycophenolic acid, which prevents nucleotide synthesis as well. And then we will move on to discussing them one by one. So first we will discuss desensitization. So a patient is considered sensitized when their panel reactive antibody is greater than 10%. However, we choose to desensitize them when they have a high PRA. What that means is when their PRA is greater than 50% prior to the transplant. And the reason for that is we have many goals that we'd like to obtain. We'd like to have a negative cross-match prior to the transplantation to reduce time on the wait list, prevent antibody-mediated rejection post-transplant, and to reduce the risk of coronary allograft vasculopathy post-transplant. So this is in these patients, when their panel reactive antibodies are greater than 50%, is when we would choose to desensitize these patients. There are many different treatment options we have listed here. They are not without repercussions and side effects as so the first one is plasmapheresis, which removes our current circulating antibodies and cytokines. Then we have immunoglobulins such as IVIG, and IVIG is kind of a catch-all. It works in many different ways, but it inhibits the complement system, it downregulates our B cell receptors, and it neutralizes our antibodies and cytokines. Then we have rituximab, which is an anti-CD20 monoclonal antibody, which is B cell depleting. So this is usually one of our first line agents to, along with the IVIG as well as the plasmapheresis, to desensitize our patients. Some newer agents that have been used and have been studied are bortezomib and carfilzomib. So bortezomib is a reversible proteasome inhibitor, which causes plasma cell apoptosis, and carfilzomib is an irreversible proteasome inhibitor, which also causes plasma cell apoptosis. Carfilzomib has been more frequently used in kind of more recently because it has less side effects than bortezomib. Bortezomib is particularly hard on patients in terms of neuropathies, and carfilzomib has less neuropathies and is better tolerated than bortezomib in our patients. We can also use eculizumab. This doesn't have as strong of evidence, however, it is an option, and it's a terminal complement activation blockade. So it's a C5 inhibitor. And finally, we have belatacept, which I had mentioned is a co-stimulation blockade, which suppresses our antibody response. Belatacept is more commonly studied and has been more commonly used in kidney transplantation, not necessarily in liver transplantation, and has been more recently studied as well in lung transplantation. But kidney transplantation is definitely where belatacept has the most literature and evidence for use. And we can use, honestly, a combination of any of these for desensitization strategies. We can use plasmapheresis, we can use IVIG, we can use rituximab. If that fails, then we can move on to carfilzomib. Then we can do carfilzomib and belatacept. So a combination of all of these can be used. So this is an example of a desensitization protocol. I've included ours at Mount Sinai. So it kind of goes through what I've said. It's a combination of many of those medications that we had discussed. We start with IVIG, and we always pre-medicate our IVIG because you can have some infusion reactions. You pre-medicate it with Tylenol, 650 milligrams, as well as Benadryl, 25 milligrams. You pre-medicate that about 30 minutes before the infusions begins. And it says you infuse over 8 hours, but we like to start it really slow and then gradually in 30-minute intervals. If the patient tolerates it, we can increase that. But it is a longer infusion. Following the IVIG completion, we will give rituximab at 375 milligrams per meter squared. The patient must sign consent for chemotherapy as it is considered chemotherapy. Also, only prescribers with our chemotherapy privileges can write for this order. And this also requires pre-medication with Tylenol, Benadryl, famotidine, and solumedrol because it can cause cytokine release syndrome and it can cause infusion reactions. And we need to have an anaphylaxis kit available. Following our desensitization, we always need to repeat our panel reactive antibody to ensure that our desensitization strategy is working. If not, we'll need to come up with a new plan and maybe try some new agents. Following desensitization.
Vala, can I stop you?
Yeah,
Vala, can I stop you there? So one question first, Mohammed, have you seen anyone getting desensitized yet? I know you've been the only one on the ward so far.
No, I haven't seen anybody yet.
So we have had a number of people, and I'll show you guys this, and it's more relevant on the transplant service, but even the pre-transplant service, whether you have a VAD or not, you can see that we send off those PRAs, or the panel of reactive antibodies. That's what determines how sensitized a patient is, and we can go over that separately. And so some of this will piece together nicely at the end when we've had some of these lectures that you can put together. But essentially, it's the number of antibodies to different HLA antigens that an individual has that determines how sensitized they are. And the more sensitized they are, as Vala said, the less likely they are to be able to have an acceptable donor that they will not reject, right? And so these desensitization protocols are all targeted, as Vala mentioned, at B cells and reducing or removing pre-existing antibodies that are circulating within the recipient's body. Does that make sense?
Yeah, absolutely.
And so 2 weeks, generally 2 to even sometimes a little bit longer weeks after a desensitization protocol, you'll check to see whether it actually worked. So I just lost a very dear patient, but that our group has been following for years now, who was highly sensitized and therefore could never get a heart. And she was undergoing desensitization with carfilzomib and belatacept. Unfortunately, she ended up having VT and VF on her LVAD and passed, but we had tried a number of different desensitization protocols on her. So just giving you some clinical relevance there. Sorry, Vala, go ahead.
No, of course.
One question, Dr. Lala, because I remember when I was rotating there was a patient we put on plasmapheresis, and that was like, she was a very complicated patient. And so is there a reason that you do IVIG versus plasmapheresis? Like, is there a clinical relevance, Vala? Like, how do you decide?
You give both. If you do plasmapheresis, you always follow it up with IVIG. So you always give both. And you have to make sure, I think something I missed was you give all of your medications like IVIG, rituximab, all of those after plasmapheresis. If you give it before plasmapheresis will actually remove those agents from the patient's body. So you always follow it up with IVIG. And then if you choose to do rituximab, carfilzomib, what have you, then you follow that up as well.
Okay.
So you're targeting it at different points in the cycle, right, Apurva? So you're not only are you removing the antibodies with plasmapheresis, but then you're kind of neutralizing antibodies on top of it with IVIG, because remember, the antibodies go on being formed by B cells. And then if you're also using an agent that targets B cells, which is preferable, then you're also killing the B cells. So there's multiple different points along that pathway that you are targeting to remove and get rid of the antibodies in a more sustained fashion.
Got it. Thank you.
If you just give IVIG, it's just neutralizing the antibodies, and then they'll come back. Not come back, but they'll be sort of the dilution factor will be gone. The same is true if you just do plasmapheresis, because you'll remove what's there, but then new ones will form.
Thank you.
Okay. Sorry, Vala.
No, of course. All right, so then we'll move on to induction therapies. So what the reason that someone would choose to have induction therapy as part of their protocol, and what it actually is it provides a high level of immunosuppression in critical early post-transplant period. And this is typically initiated intraoperatively prior to reperfusion. So the benefits of this is it allows a delay to start our calcineurin inhibitors, and it also reduces the risk of infection. But again, this is not without side effects and adverse effects that the patient could experience, as our induction agents, which are basiliximab and thymoglobulin. Thymoglobulin especially has a lot of infectious complications that the patient could experience, which we will discuss. So like I mentioned, there are multiple agents that we can use. We have basiliximab, also known as Simulec, thymoglobulin, also known as Atgam, and alemtuzumab, also known as Campath. And as always, we have our steroids, which we use methylprednisolone in that early period. So starting with basiliximab, it's a non-depleting monoclonal antibody. So it's an IL-2 receptor antagonist, which inhibits T cell activation. So the reason that this is important, and I've highlighted that it's non-depleting, is because this does not, number one, it doesn't have as many infectious complications at all, because it's not as depleting. It's not total lymphocyte depleting like our thymoglobulin is, but it's also not as potent as our thymoglobulin is to prevent rejection. The way that this is dosed is 20 milligrams given intraoperatively on post-op day 0, so at the time of transplant, and then a second dose post-op day number 4. This can be given via central or peripheral line. Moving on to thymoglobulin, this is total lymphocyte depleting. So it binds to our T cell antigens, which then causes T cell depletion. For that reason, there's a lot of infectious complications that the patient could experience after receiving thymoglobulin, and thymoglobulin can actually circulate in the body for a couple of months, up to 60 days. The half-life usually is within a week, but it can circulate up to 60 days. The doses are there for your reference, but honestly, there's different protocols for it. You can use 1 to 2 milligrams per kilogram. You can use it for anywhere between 3 to 5 days, so that's just there for your reference. This also requires pre-medications, we always give this with Tylenol and Benadryl beforehand, because this can cause cytokine release syndrome, as well as a steroid beforehand as well. We do have to adjust for platelets that are less than 75 or white blood count less than 3, because this also does causes a lot of bone marrow suppression, which could present as leukopenia, neutropenia as well as thrombocytopenia. Our
Val,
Similac,
can you-
oh, yes.
So sorry to interrupt. I'm just wanting to, I remember feeling so overwhelmed as a fellow. And so I just want to make sure that we're providing like the broader context for these kinds of the scenarios. So we don't do induction at our institution, right?
Right.
So when theoretically, and we know the renal folks do very frequently. So when theoretically would you use induction? So we talked about desensitization, which is pre-transplant. Now we're talking about induction, which is at the time of transplant. And in theory, there are some institutions that do induction at the time of heart transplantation. When would you do this?
Right. So I think I have that later on, but we can discuss that now. So when you would really do it is if patients are going in with either a positive cross match or when they are sensitized. So that's when you would kind of look to these agents. Not a lot, but I think it's kind of split 50-50 into which centers use inductions and which centers don't. And again, the ones even that do, it's 50-50 split between who uses Simulect and who uses thymoglobulin. Thymoglobulin can be for those that are really like the cross match is positive and you're really, really worried about rejection and their infection risk is lower as well. You can also use, like, for example, Simulect if you want to delay calcineurin inhibitors, because if you're worried that patient might have, an AKI after the transplant, it's kind of to preserve that kidney function so you can delay the initiation of the calcineurin inhibitor. I think for a part of the problem with some centers is that, if you do a lot of transplantations on patients that have LVADs in place, a lot of those patients with LVADs already have infectious complications, driveline infections, which could lead to more adverse outcomes if you do give them an extra immunosuppressive induction agent. But like I said, you can use it in those patients who are highly sensitized, come in, or they have a positive cross match, or if you do want to delay the initiation of calcineurin inhibitors.
Vala, is there any updated information on those patients who receive Simulect in terms of infection and then 1 year survival? I mean, I know previously there wasn't necessarily a difference in survival, and that's what we're classically taught. I was previously at an institution where I trained and we use Simulect, but is there any updated data in patients with and without LVAD getting Simulect?
Honestly, no, especially with Simulect, no, because Simulect, since it's not lymphocyte depleting, there aren't those infectious complications, and there haven't been. I have a study in here that'll show it as well. There haven't been shown even to kind of prevent or reduce the risk of rejection even. So it's still really up in the air, and I think it's still 50-50. And we can discuss the study I've included as well. Any other questions before I go on to kind of talking about CAMPATH? All right, so just moving on to CAMPATH or alemtuzumab. So this is also a depleting agent. This causes T and B cell depletion. This has really fallen out of favor. Number one, the manufacturer has really kind of limited the use of it, so it's honestly hard to obtain. But also the infectious complications of CAMPATH, especially the fungal complications, far exceeded the benefits of using it, especially in comparison of thymoglobulin or Simulect. So this has really fallen out of favor. But I've just included it here for your reference, just in case you do see it used, or if we do choose to use it for a patient. And then finally, like I've mentioned, we have our methylprednisolone, our steroid, which also causes T cell depletion. We always start at a very high dose. We always start at 1 gram given IV intraoperatively. And then post-op, we taper and switch it to oral prednisone, which I will discuss as well. So this is a study that I was actually looking at. So this looked at 80 heart transplant recipients. So it looked at thymoglobulin versus Simulect, and then the patients are maintained with cyclosporin and mycophenolate as well as steroids. At month 6, there was significantly lower like safety endpoint, so it was safer to give the Simulect, which is kind of what we would assume given the side effect profile. And then in terms of efficacy endpoint, in terms of death, graft loss, acute rejection, or in with hemodynamic compromise, there was no differences between the groups. And so this kind of led more people to choose if they are going to use an induction agent in their heart transplant recipients, to use Simulect, because it shows similar efficacy rates, but a much, much higher increased tolerability. So I included induction trends. I have 2 graphs that we will discuss, but first we consider induction trends or induction agents in patients with renal impairment, pre-transplant, or like I said, a high risk for rejection, if they're an HLA mismatch, if they're younger recipients, African American, if they already have donor-specific antibodies present, or if they're a retransplant. All of these kind of put people at a higher risk of rejection, so you might consider it in this population. And we want to avoid it in patients at high risk for infections, like I had mentioned, with patients with pre-existing driveline infections. The first figure on the left is figure HR57. So this is a graph that shows the induction agents used in adult heart transplant recipients. And this is from 2010 to 2022, actually. So this is the most updated I found. The blue line is showing that that centers that do not use induction agents, and the green line are the lines that show that is a line that shows that the centers that do use induction agents. And if you can see, it's kind of a 50-50 split. Like we had mentioned before, half the centers are using induction agents, half of the centers aren't using induction agents. Our second graph is from 2018, and this is kind of showing the differences between the percent of patients receiving induction, either any induction, IL-2 antagonist, or the polyclonal anti-thymoglobulin between Europe and North America. If you see in the yellow, that's what Europe is using. So Europe about 50%.
Someone's not on mute, so I don't know if you know who.
Okay, thank you. The yellow you can see is what Europe does. So Europe, about 50% of them use induction, and most of those 50% use Simulect. And then in North America, about 50% also use induction. And this is kind of a greater split between who uses Simulect and who uses thymoglobulin. So kind of just drives in the point of there hasn't been any conclusive evidence of one would be better than the other in terms of patient outcomes of rejection and or complications. So going on to our maintenance immunosuppression. So our maintenance immunosuppression comprises of our CNI backbone, so our calcineurin inhibitors, which are tacrolimus and cyclosporin. Tacrolimus is really the one that's more in favor, the one that we use the most often. Then we move on to our anti-proliferatives, such as mycophenolate and azathioprine, mycophenolate being the one that we use the most and is preferred. Then we move on to other alternative agents that we can use are like mTOR inhibitors, such as sirolimus and everolimus. We always have to have our corticosteroids, such as prednisone or methylprednisolone. And then we can also consider an alternative agent, such as belatacept, our co-stimulation blocker, if we need. But really, the backbone is a CNI plus an anti-proliferative plus our corticosteroid. So first we will start with our calcineurin inhibitors, which are tacrolimus and cyclosporin. So tacrolimus, they both they have the same mechanism. They're both calcineurin inhibitors, but just where they bind is a little bit different. So tacrolimus binds to the FK binding protein 12, and it stops gene transcription of cytokines. So this works in T cells. Cyclosporin binds to cyclophilin, which stops, again, gene transcription of the cytokines, and that works again in T cells as well. You can see that there's different dosing and different formulations that we have. It's usually what's been most commonly studied is weight-based dosing, where you start at 0.1 milligrams per kilogram a day. However, here our protocol is to start 0.5 milligrams sublingual BID. Our sublingual to PO conversion is 1 to 2. So 1 milligram of our sublingual tacrolimus is equal to 2 milligrams of our PO tacrolimus, and that's because we're bypassing the metabolism. So again, you would require a higher dose of the PO dose to get the same effect of the sublingual dose. Our IV to PO is about 1 to, it says 3 to 5, so we just like to do 4. If you want to be more conservative, you can do 5 in terms of the conversion. And the reason for that is it's very, we avoid using IV tacrolimus, so that's why we prefer to use sublingual in patients who, for example, if we're worried about obstruction or absorption, we like to use sublingual instead of IV because IV has been demonstrated to be extremely nephrotoxic to our patients. So sublingual is more preferred. So tacrolimus's half-life is very variable, and that's why it requires therapeutic drug monitoring. So we do have to check levels, but even with that, it's still highly variable. So our half-life can range anywhere between 2 and 30 hours. Most commonly, it's about 17 hours. But again, it has a wide range. And it does have a lot of drug-drug interactions because it's a major CYP3A4 substrate and a weak 3A4 inhibitor. So any medications, which we will talk about, that either inhibit or induce CYP3A4, so through the liver, will affect our tacrolimus level. So we really would need to be mindful of those medications being used. Cyclosporin, like I had mentioned, also is an alternative that we can use to tacrolimus. The reason that's fallen out of favor is because more studies have shown that tacrolimus has lower rates of rejection when used in our patient population. So tacrolimus is more preferred, but you can use cyclosporin as an alternative. This one is available as a PO as well as an IV, with the IV to PO conversion listed there as well. It does come in many different formulations. So it comes in Sandimmune, which is cyclosporin, non-modified, or Neurol or Gengraph, which is modified cyclosporin, and they're not interchangeable. So the reason that's important is if you have a patient being readmitted, for example, from home, and you notice that cyclosporin is on their med list, it's good to confirm which formulation that they have so we can start the right one when they're admitted into the hospital, since again, they are not interchangeable. The half-life of cyclosporin isn't quite as variable, but it does have many of the same drug-drug interactions as well, because it's a major CYP3A4 substrate as well, also a weak 2C9 inhibitor and a moderate 3A4 inhibitor, which we will discuss. So per our protocol, this is these are the target trough levels. So for the first 2 months, we'd like to have our tacrolimus 10 to 15, 3 to 6 months, 8 to 12, and greater than 6 months, you can have it anywhere between 5 and 10. But this is honestly very patient specific. Many variables can go into this dosing. For example, if the patient has an AKI, then we might want to be targeting lower tacrolimus levels. If the patient is infected, if the patient has rejection of even 3 to 6 months from transplant or greater than 6 months from transplant, we might increase the target trough of the tacrolimus. So again, very patient specific, but this is just a guidance of where to start. Same thing goes with cyclosporin. Oh, sorry.
Sorry, just a quick question just to bring the fellows in. So Mohammed, you're on a busy ICU service with lots of fresh transplants. How have you been doing this thus far? Has Dr. Moss been kind of guiding you? Have you been talking to Vala about this?
Yeah, I've been doing it under the guidance of Dr. Moss and Mala and trying to learn that.
Yeah, don't worry. I mean, it's intimidating to that effect. And I don't believe we have anyone on the service who's on cyclosporin now, correct?
No, we don't.
Yeah, we haven't
Right.
started anybody yet.
But you will see it. Sorry, go ahead, Vala. I just want to see where they're at as well.
Yeah, of course. And the dosing of this, there is I'll show you, there's like a kind of like an equation you can follow that you can try to calculate. But a lot of it's kind of like an art because there's so many different things that can affect the tacrolimus levels. Like we've kind of discussed, it can be drug-drug interactions. It's also metabolized through the liver. So if the patient's liver took a hit, then that can also affect the levels as well. We can have genetic polymorphisms to where someone can have to be a rapid metabolizer to where they require a higher dose. So although we can, at least confidently have a good guesstimate of what their appropriate level would be or the dose would be to get to their target level, there are many factors that can play into it as well. So there are many side effects to both our tacrolimus as well as our cyclosporin. The most common one that we usually talk about is nephrotoxicity. And the reason that these can cause nephrotoxicity is because they can cause vasoconstriction in the afferent arteriole. So we can see nephrotoxicity, like I said, in both of these agents. Something else is they can both cause hyperkalemia. It's more common with our tacrolimus, and that's because it can induce a kind of type 4 RTA as well. So I'm sure you've noticed a lot of our patients already have been hyperkalemic, so we'll either have to give agents to bring that down or, to kind of maneuver that, but it's always most commonly due to the CNIs. They can cause their tacrolimus can cause neurotoxicity, which is different than our cyclosporin. It can also cause hair loss, whereas our cyclosporin can cause hair growth. So that's also a difference between the two. Hypertension, hyperlipidemia is common between the both of them. Tacrolimus does have a higher rate of post-transplant diabetes, and that's because tacrolimus does impair insulin secretion, especially when used for a longer period of time. Our cyclosporin, the differences are it can cause gingival hyperplasia, can cause some skin changes. Like I mentioned, it can cause hirsutism, so hair growth. And they both do have metabolic complications like hyperlipidemia, as well as hypertension. In terms of drug interactions, these are the most common and the most severe drug interactions that you can have with our CNIs. So our CYP3A4 inducers, which will lower the levels of our CNIs, are rifampin, carbamazepine, St. John's wort, phenobarbital, phenytoin, rifabutin, and rifapentine. So most of these are our anticonvulsants as well as our antibiotics. So always be mindful if one of our patients would need to start one of these agents. In terms of our CYP3A4 inhibitors, which increase our CNI levels, those include our protease inhibitors, more specifically ritonavir, especially. So that's why if we start patients on Paxlovid outpatient for COVID, we would need to hold our the patient's tacrolimus. Azole antifungals, more specifically voriconazole and posaconazole, have a higher degree of CYP inhibition than our fluconazole does. Clarithromycin, azithromycin, and erythromycin, followed by diltiazem and verapamil. And something interesting is grapefruit juice. So although that's not a medication, we always do counsel our patients to avoid grapefruit juice, as that can increase our CNI levels, as well as amiodarone as well. So these are the recommended.
Val, sorry, I know I'm like
Yes.
the bane of your existence this morning.
No, it's okay.
So a lot of our patients, not a lot, but some of our patients, let's say, go into atrial fibrillation, they get put on amiodarone, and you said it raises the CNI levels. What do you typically do in that scenario? Will you lower the dose empirically once that starts, or will you wait for it to go up and then adjust? What's your strategy?
I think it really depends. Number one, it depends on what dose we're starting at. So if we're going to start, for example, an IV, I honestly, a lot of the times, I just kind of let it ride and especially how close they are from transplant. I like to see what the actual effect is of the amiodarone and then dose adjust. I don't necessarily empirically dose reduce like I do with our azoles or with some of our other agents, because amiodarone, although it is an inhibitor, it's not a potent inhibitor. So that's more where you would monitor before empirically dose reducing it.
Got it. Thank you.
Okay, no problem. So these are these agents, especially the azoles, we use these very commonly. I'm sure you've already seen, especially fluconazole in our patient populations. These are the ones where you would kind of empirically dose reduce, especially our voriconazole, our posaconazole, and we don't really see itraconazole, but if you did, that would also require an empiric dose adjustment. Fluconazole is very dose dependent. So if you have doses of like 200 milligrams, you might not necessarily need to empirically dose reduce as much, but you can expect about 30 to 40%. It's technically 33%, but yeah, you can use a dose reduction of anywhere from 30 to 40%. If you're using posaconazole or voriconazole, that should be a minimum of 50% dose adjustment off the bat. So 66% is what's been shown in literature, but just for ease of dose reduction, it should be a minimum of 50% dose reduction. Again, itraconazole, we don't really see as much, but it kind of would follow the same suit as posaconazole and voriconazole. And isavuconazole is the least potent in CYP3A4 inhibitor out of all of these azoles. So that one you can kind of reduce by a fourth as opposed to the rest of these agents. But again, a lot of it is dose dependent, especially with the fluconazole, but the posaconazole and voriconazole, you should empirically dose reduce off the bat when starting these medications. All right, so this brings us to our first assessment question. Patient AY is a 52-year-old female, status post-heart transplant on July 5th, 2022. Her immunosuppression regimen consists of tacrolimus 5 milligrams BID, mycophenolate 1500 milligrams BID, and prednisone 15 milligrams BID. On post-op day 10, patient has a witnessed seizure. Neurology is consulted and would like to start an anti-epileptic. Which agent would be preferred for patient AY? Would it be phenytoin, carbamazepine, or levetiracetam?
I would use levetiracetam because it has less interaction.
Exactly. Perfect. That's great. Yeah, it's always important to remember because I have been on many services where their initial choice would be phenytoin. It's quick acting, IV. I mean, you can say that with levetiracetam as well, but a lot of the times they would have liked phenytoin. However, that has a very, very severe reaction with our tacrolimus, and it would seriously and markedly reduce our tacrolimus levels. So we always like to avoid that and use levetiracetam if possible. Our next question is patient RV is a 45-year-old male, status post-heart transplant in November 2019. He's been admitted for pneumonia and cultures came back positive for aspergillus. Transplant ID is following and would like to start voriconazole. He's stable on tacrolimus 6 milligrams twice daily. How would you appropriately manage the interaction? Would you keep the dose the same and follow levels? The interaction is mild. Would you increase the dose to 8 milligrams Q12, or would you decrease the dose to 2 milligrams Q12?
Decrease the programmed dose to 2 milligrams.
Decrease the programmed dose.
Perfect, exactly, yep, because there is especially with voriconazole, it is a very serious CYP3A4 inhibitor, which would raise our tacrolimus levels, so you would want to empirically dose reduce. And like I said, at least by 50%, more commonly 66 to 70%. All right, so then we can kind of look at our tacrolimus and mycophenolate. So there was a study that looked at 314 heart transplant recipients within 8 European countries. So 77% of those patients received thymoglobulin induction. Then they were given either cyclosporin or tacrolimus with azathioprine and steroids. Then they had a targeted tacrolimus trough of 10 to 20 for the first 3 months, and then anywhere from 5 to 15. The target cyclosporin trough was 200 to 350 for the first 3 months, then 100 to 200. So this kind of shows why we prefer tacrolimus over cyclosporin in terms of our primary endpoint. The biopsy-proven acute rejection, which is greater than 1B at month 6, was lower in our tacrolimus group at 54% versus our cyclosporin at 66%. In terms of our more serious rejections, which would be greater than 3A, at month 6, again, the biopsy-proven acute rejection was lower in our tacrolimus group, which is 28% versus our cyclosporin at 42%. There's no difference in patient and graft survival at 1 year, but this really kind of reinforced why we use tacrolimus versus cyclosporin in our patient population. In terms of the pros and cons of calcineurin inhibitors, the pros are obviously these are the best choices that we have in terms of preventing rejection in any organ transplant, whether it's heart, liver, kidney, any organ transplanted. Tacrolimus has shown the lowest rates of ACR, which is our cellular rejection, and cyclosporin has lower rates of neurotoxicity though. The cons are that they both do cause nephrotoxicity. There are a lot of drug interactions, and they do require frequent drug level monitoring at first, just to kind of find where that level, that the dose would be appropriate for our patients, to where we can balance rejection versus infectious complications or any other adverse effects. Moving on to our anti-proliferatives, there's mycophenolate and azathioprine. Mycophenolate is what we use more commonly now. Azathioprine is really fallen out of favor because it has very severe myelosuppression as well as higher rates of rejection. So mycophenolate, like I said, is really preferred, and it prevents the inosine monophosphate dehydrogenase, so it prevents cell proliferation. So that's why it's an anti-proliferative. We can use anywhere between 500 to 1500 milligrams BID. With our heart transplant patients, the more common dose is between 1 gram to 1500 milligrams BID. Here at Mount Sinai, we do 1500 milligrams BID. You can always dose adjust if required for any adverse effects, the most common ones being myelosuppression as well. You can see leukopenia, you can see thrombocytopenia with these agents, and those are more specifically dose related. You can also dose reduce our mycophenolate or even stop it in terms of if patients are very sick with an infection. It comes as an IV, it comes as a PO as well, and it can come as a suspension. The only one that comes as a PO though is myfortic, which is our enteric coated, which is kind of easier on the stomach for our patients, since a lot of these side effects for the mycophenolate can cause nausea, vomiting, diarrhea. So the myfortic is a little bit easier on the stomach for the patients, but for that reason, it only comes as PO. And the way that you can convert between the two is 720 milligrams of myfortic, so our enteric coated myfortic is equal to 1000 milligrams of CellCept. And in terms of IV to PO CellCept conversion, it's 1-to-1. So if you're converting from PO to IV, you can keep it at 1-to-1.
And Val, do you want to just go over the logistics in the hospital of getting myfortic, just for the fellows? So
Yeah, for sure. For sure. So myfortic is technically non-formulary. So the way that would work is if I'm here, you can just tell me and I can put in the order through the pharmacy end of it, because it's non-orderable, I think, through the provider's end. But if I'm not here, if you can't get a hold of someone, you can always call the pharmacy, which is the Sick Center Satellite Pharmacy. They're the ones who
can't hear you, Val.
Oh, I think we lost your audio. Looks like she's gonna log back in. I'm sorry, I think it disconnected. Let me share my screen again. Welcome back. Thank you. Sorry about that. Okay, so continuing with our anti-proliferative, here are the pros and cons of our anti-proliferatives. The pros are that they're not nephrotoxic. Our mycophenolate causes less bone marrow suppression than the azathioprine. However, azathioprine is not teratogenic. Mycophenolate, however, does have greater GI side effects. So like I said, that could really be either dose limiting for our patients, so we might have to dose reduce if they're really complaining about upset stomach, whether that's nausea, vomiting, or diarrhea. And azathioprine has more bone marrow suppression than the mycophenolate, although mycophenolate does also exhibit bone marrow suppression as well. Now moving on to our continuing on to our maintenance immunosuppression of our mTOR inhibitors, we have our sirolimus as well as our everolimus. And these are mTOR inhibitors. So they bind to the FK binding protein 12. They inhibit mTOR, which also blocks cytokine-mediated cellular proliferation. And these ones, the doses vary. Our sirolimus it's a lot longer acting. So this one you would give a loading dose, and then you would have a maintenance dose, and this is once a day. So our tacrolimus, our cyclosporin, and our everolimus are all BID. So these are all dosed twice a day. Sirolimus is only dosed once a day, though. In terms of the dosage forms available, they're both only available as PO. However, sirolimus is available as a suspension if the patient has an NG tube. In terms of half-life and metabolism, sirolimus has a very long half-life. That's why it's only dose reduced once a day. And it should be taken 4 hours after cyclosporin. There is an interaction between sirolimus and our cyclosporin due to the PGP substrate. And so for that reason, it should be taken kind of farther away from our sirolimus. In terms of the everolimus, it doesn't have that interaction with the sirolimus, so this can be taken with the cyclosporin, so it can be taken at the same time. But these really aren't our first line therapies. These are our alternative agents. For example, if you're trying to avoid, again, some nephrotoxicity of tacrolimus or cyclosporin, you can kind of look towards the mTOR inhibitors along with our mycophenolate as well as our steroids. You can use that. There have been also studies that have shown some anti-neoplastic effects of our mTOR inhibitors, as well as some antiviral effects of the mTOR inhibitors. So for example, if a patient has CMV, or if you're worried if a patient has been diagnosed with cancer, which some of our patients are after transplantation, there have been studies that have shown some of these peripheral effects of the mTOR inhibitors that you can consider, which I have included here. So it inhibits growth factors that affect angiogenesis, which prevent malignancies. It can also inhibit inhibition of mTOR mediated signals for proliferation of smooth muscles and endothelial cells, which is also beneficial to prevent CAV, which is coronary allograft vasculopathy. And it can inhibit viral replication, so it can be used to prevent CMV as well. So these are some considerations you can take as well. So in terms of our monitoring, our sirolimus goal trough is between 5 and 10. Our everolimus goal trough is between 3 and 10. But again, these are very patient specific and could be individualized for the patient. Probably the most limiting factor of our use of these agents is the adverse effects. So it's fairly poorly tolerated in many studies, not only in heart transplant patients, but where it's mostly studied, which would be kidney transplant patients. It's really been shown that there have been high dropout rates in the studies due to these adverse effects. A lot of it is like mouth ulcers. There are people complaining about GI upset, edema as well. You can see a lot of it. We've seen pneumonitis or interstitial lung disease as well. And also you wouldn't want to start it immediately post-transplant because it can have delayed wound healing. And there are black box warnings that kind of discuss that as well. So that's why it's not really favored to start immediately or de novo after the heart transplant, because it can have delayed wound healing. And we only look to it usually when we are looking for alternatives to our CNIs. In terms of our drug interactions, they're very similar, if not identical, to our CNIs. So the mTOR inhibitors exhibit the same drug interaction. So again, we have the common CYP3A4 inducers and the CYP3A4 inhibitors that will increase the levels. So in terms of pros, when we would use our mTOR inhibitors is they're nephroprotective. So they don't have the nephrotoxicity that our CNIs have. Like I mentioned, it also has anti-tumor properties, low rates of CMV, and decreased progression of our CAV. But it has high discontinuation rates due to adverse effects. So if our patients, although it can have great qualities, if our patients can't tolerate it, then, those kind of, those pros and the reasons that we would give them are kind of a moot point. They also can cause impaired wound healing, like I said, hyperlipidemia, some mild higher rates of rejection. They also, same as the CNIs, have drug level monitoring and drug interactions. So moving on to corticosteroids, such as prednisone and methylprednisolone. So these kind of inhibit T cells as well. So especially at higher doses. So when you use them at very high doses, they really are kind of inhibit our T cells. However, corticosteroids have many, many side effects. Can cause upset stomach, ulcers, increased weight gain, appetite, blood sugar. So if our patients are diabetics, you might see, especially when we're using those higher doses at first, those blood pressures really, really increasing, blood sugars, I'm sorry, insomnia, mood swings. So you can really see all of this, especially you can see the mood swings for a lot of our patients immediately post-transplant. We usually use methylprednisolone, but I have our dose equivalencies written here as well. So especially if you're converting from methylpred to prednisone, the conversion is there for your reference. And we also have our protocol listed here as well. So we start with 1 gram when we do intraoperatively, and then we move on to the 125 Q8, followed by 40 IV BID, and so on and so forth until we reach prednisone 15 milligrams BID, and then further weaning is based off of those biopsy results. So the pros and cons of steroids. The pros are they're effective, very inexpensive. We have a lot of history with them. There's a lot of literature with these agents as well. In terms of cons, there's many adverse effects. And for example, the increased blood glucose require closer monitoring as steroid doses change. However, with our protocol and with our patients, eventually, if there's no rejection and if all the biopsies are great, these steroids are weaned off completely. So we don't necessarily see those long-term side effects as well. So steroids, if you, they're great at what they do and they're effective and they're inexpensive. The last agent that there have been some studies with our heart transplant recipients is belatacept, and that's an option. It's a co-stimulation blocker. So it blocks the CD28 mediated co-stimulation of T cells, and this is an IV though, there's no oral formulation of this. There is a black box warning of PTLD. It's contraindicated in our EBV negative patients. So we always have to check EBV serostatus before giving this agent. It can cause anemia, leukopenia, peripheral edema, but honestly, this belatacept is fairly well tolerated and actually usually better tolerated than our CNIs. It's not nephrotoxic, and there is no drug monitoring or severe drug interactions that you would need to be concerned with this agent. So there was a study in 2020 that looked at belatacept-based immunosuppressions, and they were more used to kind of as a calcineurin inhibitor sparing regimen in heart transplant recipients. So there were about 40 EBV positive heart transplant recipients. 6 of them were dual organs, which are heart and kidney, and 1 was a heart liver. If you see, the mean GFR was about 35, and thymoglobulin was used as an induction in 66% of these patients. Belatacept was used as according to this dosing regimen. So there's 2 different doses that you can use. When you first start it, you have your induction dose, and then you have your maintenance dose, which is every 4 weeks, starting at week 16. And this had a median follow-up of 24 months. And what was interesting was that 12 patients were switched back, or were switched, 12 patients were switched from CNIs to belatacept within 3 months. So this was the early group. And so CNIs were discontinued in 76% of the patients. And if you see, GFR improved within the first month by about 60%, and this was statistically significant. 16 patients discontinued therapy. A lot of it was due to infections or loss of follow-up, because like I said, it's an IV, so you need to go to an infusion center. So sometimes patients were discontinued because of that. So 3 out of 40 patients that presented.
I was gonna say about, when I first read this, I was also so surprised. It just shows us how much, at least for me, how much I underestimated the impact of CNIs on renal function. So when we see those changes, we were just talking about this on rounds yesterday, so I think it's kind of expected there'll be some worsening renal function, right? Like, look how many patients improved off the CNI, so.
Yeah, no, definitely.
But yeah, you're getting to the next part.
Yeah, but then the problem is then there were higher rates of rejection. So although yes, we were sparing the kidneys, there were higher rates of rejection, but this was more common in the people who were started after 3 months. So they were kind of classified as the late group that converted from belatacept to from CNIs to belatacept. But yeah, like if you can see in the graph, you have the percentages on the left-hand side, and then you have the grades of rejection on the bottom. So then you have before belatacept initiation is like the darker shade, and then the after belatacept introduction, which is the lighter shade. You can see in terms of the more serious rejection of the 2R and 3R, it was more after the belatacept introduction. It only shows the lighter shade. So for that reason, it's not favored to use in our patient population because of that higher risk of rejection. Although, like you said, it is very nice that it does spare the kidneys. So in terms of the current trends, as of 2020, I mean, it's the kind of not even a question, if you can see, about what are commonly used immunosuppression agents in adult heart transplant recipients. They're tacrolimus, mycophenolate, and steroids, which is the purple line. And then followed by, you can have either tacrolimus and mycophenolate, just dual agents, or you can have just tacrolimus and steroids. But I mean, it's kind of blows everything out of the water. The most commonly used are tacrolimus, mycophenolate, and steroids. So now going on to the last part, which is treatment of rejection. So we've talked about desensitization, which is prior to transplant. We've talked about induction, which is at the time of transplant. Maintenance, which is after the transplant. And then this is just in case someone has rejection, how do we treat the rejection? So a lot of the agents for desensitization are very similar to what we would use to treat rejection. So again, we have our corticosteroids. We have our thymoglobulin, which again is total lymphocyte depleting. We have our Campath or alemtuzumab, which is both T and B cell depleting. Plasmapheresis to remove the circulating current antibodies. IVIG to neutralize our antibodies. Rituximab to prevent any new antibodies, so it's B cell depletion. And then again, we can go to our bortezomib or our carfilzomib, which are proteasome inhibitors, which cause plasma cell apoptosis. If you see here, we don't use, although for induction we use Simulect, we don't ever use that for rejection because it isn't lymphocyte depleting, so it really wouldn't have as great or profound of an effect and isn't used for rejection. So really, it's a combination of our steroids, our thymoglobulin, IVIG, and plasmapheresis. And it also depends on the grade of rejection. So if it's just one, we don't use anything, you know. So it kind of, again, goes along with what grade of rejection there is as well. So common complications post-transplant in terms of medication-induced, We have hypertension. We do see that a lot. We have, which the causative agents are usually our CNIs and our corticosteroids. Our first line agent for any transplant, any organ transplanted, has always been calcium channel blockers. We can also use beta blockers. I know that that was more kind of controversial with the heart transplant patients. It's been historically avoided due to the thought that it may compromise cardiac output, since the heart is deinnervated and so you kind of by the acting catecholamines. But there's been more literature more recently that's shown that it can be safely used in the heart transplant population. You can also use ACEs and ARBs, but you wouldn't use that immediately post-transplant. You would use that more after about 3 months when the patient's stable, when you kind of have a stable kidney function, especially along if you're giving tacrolimus, you kind of want to avoid that initially. Hyperglycemia, CNIs, like I said, tacrolimus can impair insulin secretion, so it can cause hyperglycemia along with our steroids. Dyslipidemia, or CNIs, or corticosteroids, as well as our mTOR inhibitors. Osteoporosis, more commonly with our corticosteroids, but you can find that with our CNIs as well. NGI toxicity is really with our mycophenolate as well as our corticosteroids. So we usually start our patients on either an H2 blocker or a proton pump inhibitor to kind of help ease those GI toxicities. So patient VE is status post heart transplant 7 days ago, and it has systolic blood pressures ranging from 155 to 165. What antihypertensive agent is preferred for him immediately post-operatively? Is it losartan, nifedipine, lisinopril, or hydralazine?
B.
Yes, exactly. It would be nifedipine. Like I said, you want to avoid ACEs and ARBs, especially if someone was transplanted 7 days ago. And calcium channel blockers have really been shown to be the preferred agent in all of our organs. So in conclusion, immunosuppression is always, the management of immunosuppression is always a fine balance between rejection and infection. You know, you'll want to find the appropriate dose and at the right level for the patient. Always take patient-specific factors into play. So although our protocol might state, you know, this is our goal level or this is the dose we start at, you will find, and I'm sure you'll see as time goes on, where we might stop the CellCept, dose reduce the CellCept, or lower our tacrolimus levels, or raise our tacrolimus levels. And that's all because we're taking patient-specific factors into play. For example, with our mycophenolate, if they have the myelosuppression, we might dose reduce. If they're actively infected, we might dose reduce, and we might even stop if the infection is severe enough. So again, you'll always need to take our patient-specific factors into play. And then you can also see in this graph that shows the percentage of recipients on the y-axis, and then the year on the x-axis, and it's a percent of recipients experiencing treated rejection rates between transplant risk discharge and 1-year follow-up. And you can see that the rates of rejection have just gradually declined as the years have gone on, I think due to our immunosuppressive agents. And so I think especially what I've noticed here at Mount Sinai is we don't have as many rates, higher rates of rejection as we do infection rates. So I'm always more mindful of, you know, over immunosuppressing our patients here, especially because I've noticed that our rates of infection are higher than our rates of rejection here. So with that said, here's my contact information. I've included the other transplant pharmacists for the different organs as well. We like to cross cover each other in case someone is out. So Adina is usually who cross covers me, but just in any event that I'm not here, there's always someone that you can reach out to as well. And I can take any questions if you guys have any.
I'd say Vala, thank to the group. You've been a great resource. So I think the fellows should really lean on you, and you're there to help them. So
of course, yeah, I'm always here.
Yeah,
Call
and
me, text me,
even with we've done some LVAD desensitization. They've been extremely helpful. So
of course, I'm always here. You can call me, text me. I'm answered no matter what.
Thank you.
All right, thank you.
Thank you.